Urodynamics is the gold standard test for evaluating bladder dysfunction. This urodiagnostic study is composed of several components, including non-invasive uroflowmetry, as well as a cystometrogram with pressure flow study. Urethral pressure measurements and EMG may be added in select cases. Mediwatch offer a range of urodynamic systems suitable for performing all procedures, whether in a clinic or in a small office. Our new clinic system is designed for hospital use, while our new portable system is designed for mobility.
To turn the machine on, there is a rocker switch at the back just towards the left. The screen that you need will come up automatically after you've waited a short while. Firstly, you need to enter your patient's details. Using the mouse, alternatively, you can use the touchscreen.
The patient demographics fields are at the top left corner of the screen. Enter the patient's name, identification number, date of birth and gender. The technician, physician and referring physician can be entered at the bottom left of the screen. These can be typed in or selected from a drop-down menu.
I'm entering the indications for the test here. However, you can select a number of indications and you can put them into a drop-down list. So in future times it's going to be much easier to just choose what the indications are for the procedure.
System hardware. The Mediwatch Duet Logic G2, Sensic Clinic and Sensic Portable all use the same infusion pump, pressure transducer connectors and spinning disc Uroflow recorder. The saline or water bag is hung from the O-pole or infusion stand, and the infusion or pump tubing set is fed through the infusion pump. Open the door. Make sure the direction of the tubing is correct. Place the tube round the rollers and then close the door again and attach the end of the tube in the holder in readiness to connect to the catheters at the commencement of the test. A normal urodynamics procedure may begin with a simple uroflow.
When your patient is ready to do his flow rate, you need to go into the uroflowmetry. The machine is now ready to commence the flow rate once he starts voiding.
The spinning disc Uroflow meter is placed beneath the chair that the patient will use in the case of female patients, or placed in the appropriate position for the standing male patient. It will be ready to record continuously as soon as the voiding starts. For this to be valid, the voided volume should be at least 150 ml. Preparing catheters. For a standard cystometry study, you will need two catheters. One catheter to measure the abdominal pressure and a double lumen catheter to measure vesicle or bladder pressure and to simultaneously allow infusion of sterile saline or water into the bladder. The double lumen cystometry vesicle catheter, which is inserted into the urethra using aseptic technique, has a lumen to allow for bladder filling as well as a lumen to measure pressures. If the study is to include urethral pressure measurement as well, a triple lumen catheter may be used. Urodynamic pressures can be recorded in several different ways. You can use water-charged catheters with either disposable pressure transducers or Medex reusable pressure transducers, air-charged T-Doc catheters, or electronic microtip catheters. All give similar results, but may have a different cost to ease of use ratio. Both transducers are used in the same way with water-charged catheters. The difference is in the size of disposable item. For air-charged catheters, there is no need to flush the transducers. The transducer is located in the charge mechanism. Once the catheters are placed and attached to the appropriate color-coded transducers, they are adjusted to 0 on the screen. You will then just charge them with one click of the mechanism, making sure that PDET is 0 to 5 cm H2O pressure on the screen. Before attaching the catheters, you should prime the transducers, which will have a 2- or 3-way tap below it and a 3-way tap above it. A syringe filled with water or saline is attached to the bottom tap. Firstly, if using 3-way taps below, flush the sidearm before turning the taps to run between syringe and transducer. Then flush the transducer, slowly so as to avoid any air in the system, and flush the sidearm of the top 3-way tap, before turning the 3-way tap to run between transducer and top tap to continue flushing. The system is now primed in readiness for the catheters to be attached. Ensure connections are tight. The vesicle catheter is passed under sterile conditions into the bladder, allowing the tubing to curl up inside the bladder. For male patients, the catheter is passed up to the bifurcation and taped along the length of the penis and around the top of the catheter. For females, it is passed into the bladder for a sufficient distance so as not to fall out. After catheterization, attach the vesicle catheter to the vesicle transducer. The connectors are marked for clarity. The pressure in the abdominal cavity is normally measured by inserting the catheter into the rectum or the vagina. In the case of patients who do not have a rectum, the catheter can be inserted into the stoma. The catheter may have a balloon or an open-end, flap catheter. The rectal balloon must be placed 6 centimeters into the rectum to go past the anal sphincter. Secure both catheters to the thigh with tape, ensuring they do not touch each other. The EMG signal can be measured by placing a sponge electrode in the anal sphincter or with patch electrodes. Place the electrodes connected to the red and black leads at the 3 and 9 o'clock positions as near to the exterior anal sphincter as possible. Place the electrode connected to the green lead on the patient's hip or shin. Check the placements by asking the patient to squeeze his or her anus, which should show increased activity on the screen. Flush the rectal catheter with a syringe and connect it to the rectal transducer. The connectors will be marked. Open the taps to the patient, close them to the atmosphere, and flush through to remove air bubbles from the catheters. Air-charged catheters do not need to be flushed. Balance the transducer arm to symphysis pubis level. This is not necessary if you are using air-charged catheters.
So what I've done, I've flushed the catheters through, got all the air out of the system, I've zeroed the transducers to air, and then I've balanced them towards the patient. If we ask our patient to cough again, thank you. You can see the red line is the abdominal pressure that's inflicted upon the bladder line, and there's just a little blip there, so it's subtracted quite nicely. Our detrusor pressure is running at 0, which is a very good line to start from. And the abdominal is at just over 20, and so is the vesicular. So we're ready to go.
Recording a study. Using the event markers is very important, as this will ensure that the software is set to record all of the relevant information at each of the significant points within the study. The standard ones are first desire to void, normal desire to void, strong desire to void, urgency, and maximum systometric capacity. These should be explained to the patient before the procedure, so that they can tell the clinician about their sensations at appropriate points. During the study, you can use the other buttons at the top right of the screen to mark coughs, leaks, or custom events, or to insert a manual text comment. A catheter can be used to empty the bladder, or an ultrasound scanner can be used to check for any post-void residual volume if carrying out uroflowmetry first. Otherwise, the patient is asked to empty his or her bladder prior to the test, and the residual volume estimation can be obtained at the time of catheterization. The study will normally begin at a filling rate of 50 milliliters per minute. At this point, record the position of the patient, sitting or standing. The rate of fill can be adjusted at any time during the fill by decreasing or increasing pump flow on the event marker line at bottom of screen. During the filling phase, ask the patient to cough approximately every 100 milliliters to ensure the catheter placement remains accurate. The uroflowmeter will record significant leaks during the course of the filling phase. These leaks may be the result of detrusor overactivity or secondary to stress maneuvers that the patient is requested to perform to determine whether stress urinary incontinence is present, cough or Valsalva leak point pressure tests. The patient should void in the position they started the test. If they have moved, then record the new position and change the pressure transducer level to the new symphysis pubis level. If the vesicle catheter is expelled during the first 50% of the voided volume, then the study should be repeated. Ask the patient to perform another cough after the void to ensure that the catheters were correctly in place. Finally, again measure the post-void residual with a bladder scanner or syringe. In addition to standard cystometry, urodynamics can include urethral pressure profiles to test sphincter coordination and strength by comparing the vesicle and urethral pressures while the vesicle catheter is withdrawn from the urethra with a mechanical puller. For video urodynamics using fluoroscopy, a radio-opaque solution instead of water is used to visualize the bladder anatomy and help to further evaluate the bladder and urethral configuration, determine the site of obstruction, or when leakage occurs. Analyzing the results. Urodynamic data will vary depending on the physiologic challenge of the individual patient. The purpose of doing urodynamics is to reproduce the patient's complaints. A study which does not duplicate the patient's symptoms is not diagnostic.
Hello, my name is Jeanette Garden. I'm the Advanced Nurse Urology Practitioner working at the Heatherwood and Wexham Park NHS Trust in Ascot and Slough. I've had the opportunity today to use the new Sensic Clinic Urodynamics machine produced by Mediwatch UK. It's a very easy system to learn, and as you can see, the tracings are quite attractive and easy to interpret. I'm going to show you the tracing of a patient who I've just carried out urodynamic studies on. I'll go into patient files and locate my patient. He started doing uroflowmetry, but I want to look at his urodynamics report. As you can see, this gentleman has significant detrusor overactivity. See the waves of overactivity, and his flow is a moderately slow flow, but not too much elevation in his voiding pressures.
The new Mediwatch clinic and portable Sensic systems allow fast and straightforward testing for incontinence and voiding dysfunction, with automatic markers to aid analysis.